Thank you all. We now move on to a roundtable discussion on renal replacement therapy in acute kidney injury. This session will be chaired by Dr. Dilshan Pereira and Dr. Dumita Govindapala. Let's welcome them.
Good afternoon, ladies and gentlemen. Now we have an interesting roundtable discussion regarding renal replacement therapy in acute kidney injury. So this session will be conducted by three eminent speakers. I would like to call upon the following speakers on stage, please. Dr. Senaka Pilapitiya, Dr. Udana Rathnapala, and Dr. Dilshan Priyankara. In the meantime, I will introduce each speaker. Firstly, Dr. Senaka Pilapitiya. Dr. Senaka Pilapitiya is a specialist in internal medicine and a senior lecturer and the head of the Department of Medicine and Mental Health, Faculty of Medicine, University of Moratuwa. Dr. Udana Rathnapala is an esteemed nephrologist currently attached to District General Hospital, Chilao. Dr. Dilshan Priyankara is a consultant in critical care medicine, a consultant intensivist at National Hospital, Colombo, and he is the founder president of Ceylon College of Critical Care Specialists. To start on, I would like to call upon Dr. Senaka Pilapitiya to proceed.
Good afternoon. So we will go this in the format of a discussion. So there will be an initial presentation on the physician's perspective, and will be followed by the nephrologist and the critical care physician. So now we as physicians, when we practice, come across this issue quite often. So let's go through a scenario and try to understand the nitty-gritties of this. Let's think of a 70-year-old man who is presenting with 3 days history of fever and cough, who has a history of 20 years history of diabetes and hypertension, and who is on multiple drugs, right? Might be on metformin, glycoside, losartan, statin, and also on a proton pump inhibitor for a recently diagnosed severe gastritis on an endoscopy. On presentation, the patient is ill looking and the respiratory rate is 32 and the blood pressures are okay, and the investigation shows evidence of a bacterial infection. And this is a point where the internist will start thinking with the acute presenting problem as the major issue. But you know, in your background, he has comorbidities lasting that has been there for 20 years and he's on multiple drugs. So we go by the standard criteria like a curb or something, and then the drug would be intravenous beta-lactam and a macrolide. And we start, and to see by the third day the condition is still worsening. So empirical antibiotics seems to be not working, but he's deteriorating. So our main thought is on how to handle this part. So we'll be looking for any evidence in cultures and trying to think over changing the antibiotics. But at the same time, we see that there is another problem emerging. The serum creatinine is 1.9. So that indicates to us he's heading towards another issue. We know because of the comorbidities he's at high risk, and on top of that, he's on certain drugs. So at this point, it alerts that we have to take necessary precautions for AKI. And how do we revolve around that? So acute kidney injury is just an abrupt or rapid decline in the renal filtration. And we have 3 parameters to get an idea whether our patient is heading towards it. So it's either looking for serum creatinine, azotemia, blood ureas, and reduction in urine output. Now, we will be alert on this, and but we have to keep in mind that with the immediate renal insult, all the time, we might not get a rise in creatinine or blood urea nitrogens. So it might be the first, might be your reduced urine output. So unless we are vigilant, we might still miss the initial phase. And what other criteria can be used? We have several like rifle, Akin, and the KDIGO. KDIGO being the most recent and the most commonly used. So we have few parameters. We'll be looking at the serum creatinine, whether there is a rise of 0.3 milligrams per deciliter within 48 hours, or whether there is an increase in 1.5 times from the baseline during the last 7 days, and the urine volume, whether it is less than 0.5 ml per kg per hour. So far it's simple. We are looking whether he is heading towards AKI. And also the rifle is quite attractive in our setup, because if you see, you can go by this, you will identify the risk stage where the creatinines go by 1.5 times the baseline. So we know it's at the risk stage. And if you detect, for example, the pre-renal condition and so on, we can intervene and correct. Then the other parameters are there to diagnose injury and failure. So how often do we come across? What's the prevalence? Do we have studies? Locally, of course, the data is scanty. We don't have much. But world over, if you see, the prevalence of AKI in a general medical setup would be somewhere between 3 to 5%. There are some UK studies showing 7% prevalence. So it's a fair, a common problem that we would face. What about our data? There is one publication from Herat and al. From the Colombo North Teaching Hospital with a cohort of 333 patients. So going through this will tell us in which patients should be thinking of AKI, early. So in his cohort, which is published, nearly 60% has been secondary to infections, right? So even this patient who is having a low respiratory infection, these people are high risk. And if you take pyelonephritis, this could be both from the medical and surgical units. So has had about 10%. Then leptospirosis. Now this is a Colombo North Teaching Hospital, but so when it comes to conditions like leptospirosis and snake bite, there will be a variability based on where you practice, right? So if it is at Anuradhapura, of course it is seasonal. In a particular seasons, it will be very high. In the North Central Province, if you take the snake bites, the incidence will be very high. So you see that when it comes to the prevalence, and we will see that there's a regional variability as well. So our alertness will differ even according to the region we practice. Then quite interestingly, 1/3 has been on ACE inhibitors, which is fairly understood because these are fairly common NCDs. And 15% had been on NSAIDs. So again, this is with the previous 2 weeks. So nothing much the physicians can do at that point. But one interesting thing is that 1/4 of the patients at the presentation to the nephrology unit has been dehydrated. Now, something that we will have to think of, about the fluid status on people who are impending acute kidney injury. And 1/3 had diabetes, 1/3 has hypertension, and coronary artery disease in 15. Again, this will vary regionally. So if you think of North Central Province and certain other areas, you will have, ongoing CKDU or the agricultural nephropathy. On top, this incidence will be high. So how have they presented to the nephrologist? So according to this, they have seen about 15% with oligoanuria, and about 10% with hyperkalemia, another 7% with metabolic acidosis, and about 3% fluid overload. Now, what it says is only about 1/3 of patients have had an issue that would have been really needed some renal interventions, or even some of them are still manageable in the internal medical setup. And out of the patients in this cohort, only 23% has undergone hemodialysis. So the rest has been again managed with other modalities. And so these are the data on discharge. Only about 12% has died, and the others have had a fairly good recovery. So when it comes to acute kidney injury, from a physician's perspective, we can keep it very simple in the beginning by just going through the pre-renal, renal, and the post-renal causes. In our setup, we will mostly dealing with pre-renal and renal. So how do we go around it? The first thing is just to think fairly simply, how can we avoid pre-renal? So the impetus for glomerular filtration is nothing but the pressure gradient between the glomerulus and the Bowman's capsule. Now that's what we have to keep in mind. If we can maintain that, we make sure that our patient doesn't go for a pre-renal injury. And it's by making sure that your efferent and efferent arterial resistances are being maintained. So what are the common ones we see? We see hypovolemia, like common things like hemorrhages, gastrointestinal loss, and dengue. Then hypotension, we know the causes. And both these will reduce your renal blood flow, and that will lead. But then renal vasoconstriction, so we are careful about the drugs. That is how they bring about these issues, acute kidney injury. And we have to keep an eye on ACE inhibitors and ARBs and stop them at the right time. So you can remember our patient was on this, and early we should deal with it. Then of course the intrinsic renal causes, I'm sure Udana will go through this in detail. Here, thing that the internist can do is to hit hard on the cause. So if it is leptospirosis causing acute interstitial nephritis, we can early, treat without any delays. So likewise, it's either hitting hard at the cause or early referring to the relevant specialty to go for a diagnosis. So all in all, our role as internists will be to identify the risk factors, to identify who is going to get this, and modify them, reassure they get a proper fluid resuscitation, we adjust their medications, and addressing the underlying cause. And when it goes beyond a certain point, we need our colleagues to come in. And I think from here onwards, Udana will elaborate to you at what point they would prefer best these patients to be referred. And as we go on, let's ensue on the discussion on this.
Yes, thank you very much, Dr. Pilapitiya, for the fantastic start. And of course, my life has been made very easy to go on from here. But a couple of questions, we should have waited for the audience, but let me ask a question. Should have we stopped omeprazole? Patient was on omeprazole. What is your practice? Should we stop omeprazole? Once again, it's a tricky answer. Omeprazole gives to acute tibial intestinal nephritis in 1 in million. So it's such a rare side effect. So stopping omeprazole is not a need at this moment. So it's always any drug as per toxicology, you have to weigh the benefit versus the risk of the particular drug. For if this patient was a bleeding patient or at risk of upper GL bleeding, I would keep the patient on omeprazole and, wait, and watchful waiting is what nephrologists most of the time what we do. So I would keep the patient on omeprazole. If there is no other obvious cause, yes, let's think about stopping omeprazole. So stopping omeprazole is not a must, when you see omeprazole in your drug chart. Then the second thing is there was a 12% mortality in that particular study. Are you happy that it's 12 is 1 in 8? Not bad. 1 in 8 going to Dilshan's, not me. Under Dilshan's care, going to die of AKI. Happy? No. Okay. So Dilshan has to clear the drugs in NHSL MICU. So it's a busy place. So that, one means to send them up. Other one is to send them back through the door. So I would like to get them back. So the current strategy of the International Society of Nephrology, all the nephrologists are a part of it, is we have a project 0 by 25. So I have to tell about it. So our legacy is to make 0 preventable deaths by 2025. So that's, when we get an invitation for AKI, so we never say no, because we are towards that goal of going towards 0 deaths by 2025. So now coming to the management of AKI. So as per guidelines, as per practice of the nephrologists, we follow a very, very simple rule. AKI is not that complex. If you can get the first slide, please. Yeah. So, yes. Oh, okay, thank you. Yeah. So the first step, I'm going to talk about 10 essential steps. It's not very, very complicated. And this is what 2012 KDIGO guidelines would have given you if you go through 345 pages, but I'm going to give it in 10 minutes. So let's see, avoid nephrotoxics. So this I took as the first step because the patient is septic and he is to get a vancomycin dose at 8 a.m. in the morning, and the time is 7:55. So if you look at the drug chart, we could have prevented the calamity of giving a nephrotoxic drug. So it's always good when you see a rise of creatinine. Now, once again, it's a controversial area. The rise of creatinine may not to be above the normal range. For example, if your creatinine is 0.6, you are for example, Dr. Dimita being a very small made lady, her creatinine would be somewhere around 0.6. So 0.3 rise would be 0.9. Still, it's below the normal range. So you have to be very vigilant when you are looking after a patient who has got what we call potential AKI, they can develop a potential AKI. So you have to know the risk factors. So with the rise of 0.9, if you look at the drug chart and stop all these nephrotoxics, you can make your life as well as nephrology's life very easy, and you could have saved one of those 0/25. And the notorious nephrotoxics are, contrast is not good. So you always discuss preferably with the nephrologist when the eGFR is 45, and all non-steroidal. So if there is any what we call the wrong idea in the group that there is a non-steroidal safe in AKI, the answer is no. All the COX-1 inhibitors, all the COX-2 inhibitors are nephrotoxics, including Sulindac. Now, it was there until 2014, but a meta-analysis clearly showed out even Sulindac is also nephrotoxics. Then antibiotics, gentamicin and vancomycin, all these things, antivirus. But two important things regarding ACE inhibitors, ARB, already Dr. Pilapitiya highlighted, because losartan, valsartan, candesartan, enalapril, perindopril, captopril are all beneficial drugs in the long term. For diabetic kidney disease, that's the drug. For heart failure, that's the drug. But not all good things in the long term are beneficial in the short term. So whenever you see AKI, a rising creatinine, a falling urine output, you should stop these drugs. That's called a sick day rule. Now, it's there in the guidelines, but it has not come into practice for some reason. That's why I want to highlight, whenever you see AKI, a falling urine output, you should stop SGLT2 inhibitors and ACE inhibitor ARBs temporarily. Then all other drugs are rare drugs. So let me move to the second management step.
Yeah, before that, can I clarify a small thing from you, Udana, regarding the antibiotics, right? So if the patient's culture is sensitive to vancomycin and no other drug, then you see this rise in the creatinine. Whether you would give the full dose of vancomycin within the initial 48 hours, or still you reduce according to the renal functions and give the low dose. That's my question to you.
So the answer is I can't give the answer. So because it's a multidisciplinary decision. So I would discuss with my microbiologist and the physician who's treating whether sepsis is going to kill the patient or AKI is going to kill the patient. If the answer sepsis carries more risk, still I would, just forget about the kidney. Let's give the full dose for 48 hours and then we'll cut down the necessary. So there is no hard and fast rules as such. So it's always depending on the assessment of the patient by the multidisciplinary team. So moving the optimal fluid management. Once again, there is a practice among ourselves. Since septic shock, the management guidelines gave us a clear value, 3 ml per kg over 4 hours of crystalloids. Now that management has come to AKI practice, which is wrong. Now for septic shock, that's absolutely correct. Patient is in shock and patient's organs are hyperpervious. Yes, you can practice that huge amount of 3 ml per kg per hour. For Dr. Dumita, it's a small amount, but for me, who's almost 90 kilos, it's a huge amount. 30 kilos, 30 milliliters per kg into 90 is 2,700 over a couple of hours. If the patient is already in fluid overload, you are going to kill the patient of pulmonary edema. So the correct way of looking at the AKI is to do a proper fluid assessment clinically, as well as, Dilshan is the expert of using the echo and ultrasound scan and everything for assessment of fluids. But simply, as physicians, we can look into this. On your left, it's a fluid overload patient. On your right is a dry patient. So assess the fluid status before deciding on the fluid therapy. Then too much fluid and too less fluid increases your mortality. So you have to find the optimal fluid therapy for this patient. Is there a value like 100 ml per hour, which we practice? There is nothing as such. So it's always an individualistic decision. So you have to assess and treat. Then what is the ideal IV fluid? We all know the answer. Hydroxyethyl starch is contraindicated because of the high mortality. Albumin is expensive. Dilshan is always talking to the ministry to reduce the use of albumin in this country. 0.9 saline is also not preferred. I'll tell you the reason. The preferred solutions are balanced crystalloids, where the osmolality is similar to our plasma, and those are ringalactate and plasmalite, and we have ringalactate. And 1.26 sodium bicarb is within our authority. Nephrologists do use a lot of 1.26 sodium bicarb. That's because when there is superadded metabolic acidosis, you can't use 8.4% due to multiple reasons, but 1.26% is available in other countries. We can make 1.26 for ourselves if there is significant acidosis in a non-oliguric patient. And the reason for saline being not being the favorable IV fluid is because if you look at the chloride, saline carries a lot of chloride, so hyperchloremic acidosis. So if the patient is already acidotic, the saline can cause the problems worse. So my dear friends, 0.9% saline as per current evidence is not the preferred drug, especially in septic shock and AKI management. Then place of furosemide. I think we all use furosemide. What is the answer? Who say furosemide can be used in AKI? In the audience? Yes or no? Some yes, some no. There's no, now most of the junior doctors in the audience says no. There's no absolute no in this world. You know, when you become senior, like, not like me, I'm still young, but like Dr. Pilapitiya, okay. Okay. Yeah. There is no yes, no answer. There is always a gray area. So furosemide is beneficial at certain points. Furosemide is non-beneficial at certain points. As per research data, furosemide does not reduce your mortality. So there is no point in giving furosemide. But for a country like ours, where if this patient is oliguric, you have to dialyze the patient early. Have you got anyone who has got enough renal replacement therapy or dialysis in your wards or in your ICUs? No. So because of that, in developing countries, we like to make the oliguric AKI to a non-oliguric AKI if possible. So furosemide used in AKI is not wrong, but it does not give any added benefit. I won't say it's detrimental anyway. So, but there's a clear indication for use of furosemide if the patient is in pulmonary edema, producing urine with the AKI. You can always give a shot of IV furosemide. It's not a contraindication. It's clearly beneficial if the patient is in fluid overload, especially in Dr. Namal's case in cardiac failure. So no questions asked. Then maintain hemodynamics. So the important thing is you have to go for this value, because one unit may be practicing at a blood pressure of 110/80. You're happy. Yours is 130/70. No, you can't basically save patients like that. For renal perfusion to occur, you need a mean arterial pressure of at least 65. Once again, is it the absolute value? I told you there is no absolute value in this world. You can have it between 65 to 90. If the patient is chronically hypertensive, the kidneys won't perfuse. So you have to keep them a bit high for kidneys to get perfused. So please maintain a MAP of 65 in all your patients. So the preferred inotrope, I know dopamine theory is not there anymore. Dopamine is not renal friendly. That's has been disproven. So the first line would be noradrenaline, then comes vasopressin and adrenaline. And if there is cardiac failure, dobutamine gives an added benefit. But dopamine is not the first line anymore. The renal protective effective theory is disproven in the current scientific arena. I think, so these are the simple stuff.
Yeah, before we move on, can I just clarify another thing? So you were talking about sodium bicarbonate, IV 1.26. Is there a place for oral sodium bicarbonate? Because we use it for CKD, but in the acute setting of acute kidney injury.
Yes, so once again, please, now we are talking about CKD and AKI. So let me give the correct answer. For CKD, the bicarb is recommended as per 2024 guidelines when the ABG shows a bicarbonate value less than 22. So it has become a practice of the nephrologists and the physicians to add sodium bicarbonate. I would say erroneous. The guidelines never help it, because sodium bicarbonate contains sodium as a internal moiety in it. So sodium is LUNU. So you ask the patient to avoid salt, go for a low salt diet, and you load the patient with sodium bicarbonate. So it's not good. The other problem of giving bicarb, oral sodium bicarb is converted to carbon dioxide and H2O because it's carbonic acid. Then so it can cause carbon dioxide narcosis if you give too much of carbon dioxide in ICU patient in AKI, and it's quite a drug that causes discomfort. because of the carbon dioxide production in the stomach. So once again, you have to balance the benefit of this. So without a documented acidosis or a type 4 renal tubular acidosis in CKD, I don't see value of adding sodium bicarb. In AKI, you are putting me in trouble. Or I think there is another nephrologist in the audience, so probably she can give the answer. But oral sodium bicarb, so I would say I would go for IV sodium bicarbonate if it is indicated. If the pH is very low, below 7.1 like, with a bicarbonate value less than 10, these are not, these are, you can rate, criteria for evidence, expert opinion. These are not in the guidelines, but I won't go for bicarb or sodium bicarb in AKI.
Thank you.
Yeah, thank you, Udana. Now I think he elaborated on what we can do before making the referral to the nephrologist. And one of the common dilemmas we face every day is like when we refer with the expectation of commencing on renal replacement therapy. So we have done the baseline things, but we always have this sometimes the dissatisfaction between the two categories of not initiating at the right point, and from their point of view, they also have their own arguments. So I would like to say now from our point as an internist, what I would say is we treat for an infection and we know that the patient is becoming septic, and the empirical antibiotics we were using, a culture report comes and we see, we know that now they were not effective. And so we have embarked on the right antibiotic. But we know with the physiological variations, now with the time taken to act with this antibiotic, there will be another about 48 hours or more, which we know that the patient is going to crash. So we want to get things better before the patient crashes. So that's the point why we are concerned. But I think the nephrologist will have their own concerns in making this decision. So I would like Udana to elaborate on that. Why do this conflict occurs between two us?
So, Dr. Pilapitiya, you are putting me into deep waters now. Because one wrong word can, make a calamity in this audience. Okay, so let me try to be very, very cautious and cunning in giving this answer. Okay, so I have to reveal a secret of nephrology. Only two in the audience, so I can reveal it. The college is not there to back up me, because dialysis is not a miraculous therapy, and hemodialysis itself carries a lot of complications. For example, you have to get a line in from the right interjugular left-femoral, which can give rise to complications, infections, these things, even arrhythmias when the potassium is high, so it's problematic. When you do dialysis, you have to get the blood out at a rate of 300 mils per minute, so you can very well collapse on dialysis, and especially in AKI. So dialysis, all in all, is not a safe, what we call is not a first-line treatment by all the means of practice of nephrology as far as we are concerned. And if you look at the evidence, even 2023 meta-analysis, it has been comparing. Now, myself and Dilshan being involved in CRRT for 5 years in this country, we have been looking into data almost always for last 5 years. The intensivists and nephrologists have compared early initiation of renal replacement therapy versus late initiation of CRRT. And almost always the answer has been early is not beneficial. Early may be detrimental. Now, there is a special disease entity called artificial kidney-induced kidney injury. Artificial kidney is the dialyzer, and dialyzing alone can give rise to problems. So, what we practice is we looked at, if you can get, I think I have got a slide related to this question. It should be a slide. Yeah. So, if you look at the conventional criteria, I'm waiting for the slide, but let me see. Now, the conventional criteria for dialysis are, you try it medically and you fail in case of refractory hyperkalemia. It's not just a potassium of 6. You try managing with insulin dextrose, so on and so forth. No, let me go to that slide. I think it should be somewhere here. Yeah, so this is the slide. So, if any of the following are not responding, now these are nice recommendations. So, these are pure and simple from the book. So, refractory hyperkalemia, you try to correct potassium, not responding. Refractory metabolic acidosis, symptoms and complications of uremia, fluid overload, and of course, I would say refractory pulmonary edema are the indications for hemodialysis. The reason for the difference of opinion between the physician and nephrologist is probably due to the complications that we see on dialysis, which you don't see. So we like to wait and let the natural history help the patient rather than, putting the patient into invasive treatment. And the definition of AKI, if I want to add something for Dr. Pilapitiya's definition, which is in the books, but in practice, the definition of AKI is sudden, abrupt decline in GFR, which is, so I won't pass any of the trainees if you don't give this definition, sudden, abrupt decline in GFR, which is partially or fully reversible. So AKI, by definition, my dear friends, is reversible. So you have to wait until it comes back. When there is no return, when the patient goes to a point of no return, after meticulous assessment, you take the decision on dialysis. So almost always nephrology decision will be late and physician's decision will be early. Once again, the way forward is good communication between the team and make a multidisciplinary approach and take the decision.
So I think from here, now if we think of a even worse scenario, I think Dilshan will come in at that point. So I would like to say, if the patient has now deteriorated, is septic and is in shock, and the blood pressures are not stable for hemodialysis. So I think, so from there onwards, it will be Dilshan who will be playing the main role. So over to you, Dilshan.
Dilshan, before you move forward, CRRT, nephrologist job or your job?
Thank you. So I was asked to, come for a round table discussion. I was thinking, what is this round table? Then I saw this round table. So there are basically 2 round tables. So then I realized, okay, this is the round table discussion. Okay. So now Dr. Pilapitiya started the case. So I just, made this patient critically unwell, to discuss further. So this patient who came with the pneumonia, now getting really unwell and coming to ICU. GCS is confused, tachycardic, maintaining the blood pressure with noradrenaline, quite high dose, vasopressin, oliguric, and blood gas showing a metabolic acidosis, a bit of lactatemia, and rising creatinine. So my question, does AKI impact this patient's outcome? Hands up who says yes. Hands up who says no. Hands up who says who. Right. So, so the data is coming from this large trial, epidemiology of acute kidney injury in critically ill patients, published in 2015. So in there, so it was done in 97 centers. So AKI incidence is quite high, around 60%. So 60% of your patients in your ICU will have some degree of AKI. Then in that study, close to 15% of patients had some sort of renal replacement therapy. And when you look at the stage of the AKI, the mortality goes high. So if you have a patient with a stage 1 AKI, the mortality doubles. If you have a stage 3 AKI, the mortality goes 7 times higher than usual. So if you add that to a patient with a septic shock, who has a 50% mortality, so are dealing with a really unwell patient who has an AKI with septic shock in your ICU. So you're discussing about what options we have as renal replacement therapy. So there are several options coming from continuous renal replacement therapy or also sustained low efficiency dialysis into intermittent hemodialysis. So which therapy you're going to select in these patients? Is one or the other is better? Is a question. So if you prefer to go for a CRRT, the patients would be like, patients who are cardiovascularly unstable, who will not tolerate a large blood flows going out from their circulation into the machine. And patients who have metabolic acidosis, who needs a volume control is better with this. And also patients who have significant cerebral edema. So patients who have, encephalopathy, so they better tolerate this CRRT rather than a rapid change in the volume and the sodium, which will worsen the encephalopathy. So you have to balance between them. So on the other hand, you have a patient who's profoundly hyperkalemic and profound acidosis, who have a drug poisoning, and where you have a problem with anticoagulation, because CRRT is a slow process where you always need an anticoagulation. So in these patients, but you prefer an intermittent hemodialysis or in between a sort of a low blood flow extended dialysis. So you have to decide which therapy you're going to prefer in your particular patient. So all these factors come into play when you want to decide on this. So the next question, now we have this patient in the ICU. So when would you start therapy? How many of you start the CRRT or whatever the renal replacement therapy now? Hands up. No one? Who's going to start later? Okay. So it's a question, isn't it? So we are in a dilemma. Are we going to put this patient or start patient on CRRT or whatever, the renal replacement therapy? So coming into, some of the differences I just want to highlight, the intermittent hemodialysis versus CRRT. Obviously, the blood flow rates are lower in continuous slow CRRT, whereas intermittent hemodialysis, you can go up to 500 ml per minute. But the problem is, I've seen in dialysis units, they still use the low blood flow rates for a patient who is CKD, good hemodynamics, still use the low blood flow rates, where the starting creatinine was 6, after dialysis, creatinine is 7. So you're asking why the patient has not got dialysis, because your blood flow rates are not enough. The dialysis flow rates, if you see, it's quite high. So intermittent hemodialysis therapies are faster and quicker. It removes your solutes faster compared to CRRT therapies, where it's continuous and very slow. So before starting, I asked you a question, now I'm going to start. Before starting any in CRRT, say CRRT, you're going to start in a CRRT, what factors or what are the things that you should consider before initiating this therapy? So I would say, what's the patient's background physiology? Now we have a 70-year-old patient who is critically unwell coming to ICU. Are you going to put this patient on CRRT if this patient who was, who can't even walk for 10 or 20 yards, and put him on a multi-organ support? Quality of life. We never assess this, isn't it? These patients, even if they recover, they will have a very prolonged course, maybe in the ICU, maybe in the ward, or even maybe if they once they go home. Patients' wishes. Would they ever wanted this sort of therapy? I've seen patients who never wanted hemodialysis. When they put a tube in, sedated, we do whatever we want, isn't it? We put them on a dialysis, and sometimes the outcome may not be the ones you wanted. Cost, CRRT is very costly. So you have to remember, you are putting an expensive therapy. If you're putting an expensive therapy in a patient who's probably the recovery is poor, or maybe the quality of life is poor. And will it cause harm to the patient? Of course, I think Udana was talking about the vascular access. Yes, it's associated with a lot of problems. Anticoagulation, they can bleed, they can have line-associated infections, so you have to think about that as well. And train staff. So don't start CRRT if your staff is not trained. You'll be losing a lot of kids. So much of money wasted if your staff is not trained. So the indication, they were talking about the indications, so I also like to highlight this. So what the key regio says, initiate RRT emergently when a life-threatening changes in fluid electrolyte acid-base balance exists. So that even though it's not graded, it's clear. But they have made a statement, consider the broader clinical context, the presence of conditions that can be modified with RRT, and trends of laboratory tests rather than single blood urea creatinine threshold alone. So blood urea creatinine will not purely tell this patient needs dialysis or some form of renal replacement therapy or not. It's a broader context. You look at the patient as a whole and decide whether this patient needs some sort of a renal replacement therapy. So key elements, if you think this patient needs some form of renal replacement therapy, what modality you're going to start? I told about the CRRT and the intermittent hemodialysis differences and the dose. So this is also very important. If you start them on CRA, get them a proper dose. Otherwise, your therapy is not effective. Anticoagulation, again, you have to decide which anticoagulation is the best. At the moment, citrate is the best out of the anticoagulation in CRRT. And the vascular access, I'll come into vascular access later, and the nutrition support. So CRRT per se is not, now Udana was asked, is a nephrologist entity. I would say it's CRRT is not just for your kidney. It's supposed to every system. If you want to control your temperature, you can do it. Even in acute hepatic failure, you might use it. So it's not just a single organ support, it's a multi-organ support. And also you have the other extracorporeal device that you can connect it. So what you should aim, effective clearance and a best circuit survival. If you have an effective treatment with the CRR, the patient would be happy. If you have a best circuit survival, the circuit would be happy, or the machine would be happy. So you have to balance both. So I've just skipped this. So one of the main problems with CRT would be clotting. So the nurses say, doctor, the CRT clotted. So I would just brief you for the audience. The main important factor would be the vascular access. And there are others, the filter and the deaeration chamber in the CRRT machine and the anticoagulation. I'll just skip because of the time. So I just, because you all, the registrars, the SARs involved in line insertions, so I would like to tell you about the lines. So the internal jugulars are the preferred, where the right is the most suitable one, where it's a straight access to the right atrium. But there are disadvantages. When the patient is severely acidotic, the veins can collapse. Subclavian is the least recommended. Femoral veins are good, but it is associated with infections. So RIJ is preferred, subclavian is least recommended, and do not use lumens with three-way connections because their lumens are large. So again, if you have a person, if you're putting a right IJ, go for 15 centimeter. If you are going for the left, go for 20. And if your femoral, it should be larger. And so the tip also is very important. I have seen some of the lines the halfway is out. So you're not going to get an effective CRRT because your blood flow rates are not good. So your tip will be at the SVC atria junction. If you see this picture, you think it's correctly positioned or inappropriate position. So people believe that the SVC atria junction is at the carina. No, it's wrong. So if you look at this chest X-ray, you see the carina. You see the carina. You can see the carina clear, right? So SVC atria junction is below because the SVC comes behind the right atrium and joins below. So this is the carina, but your right atrial SVC junction is lower than that. So there's a way that you can check whether it's at the appropriate place. You can count from the vertebral bodies and the intervertebral discs. So ideal place would be at the SVC RA junction, not in the superior SVC. Yeah, that's it. So I just want to highlight in this case. So the importance of whether you're going to start, so you have to make a decision as a, you take the patient as a whole and make the decision, are you going to start them on CRRT? And because it's associated with problems and you might not, get the benefit out of it. And some of the practical points I just want to highlight. Anything else if you want to ask or the moderators want to ask, I would like to answer them.
Yeah, with the time, I think we will wind up this discussion unless there is some burning question. So what we tried was to see the physician's perspective of acute kidney injury. What are the instances where we have to be very vigilant and how can we detect it early and how to try and avoid it or treat it within our purview, and what is the right time to refer to our colleagues. And also, when we heard from both the other colleagues, what makes them make their own decisions. So it's always a collaborative effect between the different interprofessional groups to have a detailed dialogue, express your concerns, and also hear to their concerns and take the right decision. So I think that's what we tried within this roundtable discussion. And I think I would like to thank both the colleagues for attending this and giving their valuable opinions. Thank you.
Before we wind up, may I now invite Dr. Dilshan to hand over the tokens of appreciation to all three speakers of this session. Dr. Senaka Pilapitiya, Dr. Udana Rathnapala, Dr. Dilshan Priyankara. Thank you.